Okay, so hello everybody. Welcome to that first free paper session. Topics in that free paper sessions, and we will have four excellent presentations here: is advanced life support and special circumstances. My name is Carsten Lott. I'm the co-chair education in the Science and Education Committee Advanced Life Support. And with the guidelines 2020, I had the great pleasure to coordinate the special circumstances chapter. And I'm happy to introduce my co-chair, Sebastian Schnaubelt.
Hello everyone, I'm Sebastian Schnaubelt from Vienna in Austria. I'm co-chairing this session together with Carsten.
Fine. So, not to waste any time, I would like to start right away with the presentation of Laura Bruning from the Netherlands. And she's talking about evidence behind the ABCDE approach. Laura, I'm really looking forward to that. As I just stated in my presentation in the guideline session, if somebody studying cardiac arrest, use the ABCDE approach. So I'm really looking forward to what you're going to tell us about that.
Hello, my name is Laura Bruining. I'm a pediatric resident, and together with Marjolein Linders and Marije Hoogeveen, I performed the scoping review. We're from the Radboud University Medical Center in the Netherlands. So you can start the video now. Today, I would like to tell you about our scoping review about the ABCDE approach. The ABCDE approach, acronym for airway, breathing, circulation,
We do not have the video at the moment. Okay, so it's just getting back. So apologies, seems to have problems with the host. So just for information to everybody, we have technical issues, but I'm pretty sure this is going to be solved in a second.
Hello, my name is Laura Bruining, and today I would like to tell you about our scoping review about the ABCDE approach. The ABCDE approach, acronym for airway, breathing, circulation, disability, and exposure, can be used in the assessment of all critically ill and injured patients. It helps the healthcare professional to systematically assess a patient following the treat first what kills first principle. The ABCDE approach is nowadays recommended in international life support courses and guidelines. However, solid evidence about the benefits of the approach and literature about the ABCDE approach seems to be lacking. The purpose of this study was to create an overview of research on the outcomes of the application of the ABCDE approach. A comprehensive scoping review was performed, including an a priori protocol following the PRISMA extension for scoping reviews. PubMed, Embase, CINAHL and Cochrane Library were searched to identify papers regarding healthcare professionals applying the ABCDE approach in medical care situations or in a simulation setting during life support courses. 2 independent reviewers screened studies for inclusion, and data extraction was performed by using a piloted data extraction table. As you can see in the results, 25 out of 5,269 studies met the inclusion criteria. 2/3 of the included studies had an observational study design, and 8 studies had an experimental study design, of which 1 was a randomized controlled trial. 56% of the included studies took place in real medical emergencies and 44% in simulation setting. The pie chart shows the distribution of disciplines in the included studies. And as you can see, 80% of the included studies were conducted in trauma patients, of which 7 specific in pediatric trauma patients. And 10 studies were conducted in pediatric patients, 2 in general pediatrics, and 1 in neonatology. This review focused on identifying the reported outcomes about the ABCDE approach, and no patient-related outcomes were identified. Only professional outcomes were found: adherence, time to complete assessments, skills and knowledge, confidence, impact on work, frequency of application, and communication. Adherence and time to complete assessment were most described outcomes, and as you can see in the table, there was a huge variation among the included studies. Another interesting finding is that there were several terms used to describe the ABCDE assessment, such as primary survey and primary assessment, and evaluation of the ABCDE items assessed in included studies showed different items were assessed, and 6 studies did not explain which items they assessed during their ABCDE assessment. In conclusion, our scoping review shows literature reporting outcomes of the application of the ABCDE approach is scarce. Only professional outcomes were reported, and the ABCDE approach is not universally described in literature. For future research, our recommendation would be to focus on patient-related outcomes, and it might be interesting to investigate the need for a true universal ABCDE approach, for example with supplements for specific emergency care situations such as trauma or neonatology. Thank you for your attention.
Yeah, thank you very much, Laura, for that excellent presentation. That was really nice. Yeah, I'm going to start with the question. So, as you show that there's not that much evidence behind the ABCDE approach, do you think it's a useful approach at all? You're still muted, Laura.
Yes, I still think it's a very useful approach. It gives the healthcare professional a structure to systematically assess a patient. So I think that's very important in acute care situations.
Okay, now I got the question from Teresa Olaf Swingen. She asks how you would design a study to find out how or if ABCDE works.
I think it's very difficult to design such a study, but I think we found adherence in the included study varies, and I think you can design a study, for example, in emergency department of a hospital where you compare the adherence to the ABCDE approach to the patient outcomes or time to diagnosis, for example.
Okay, yeah, so thank you very much for that nice presentation. I'm conscious of time, so I'm going to hand over to Sebastian to introduce our next speaker.
All right, thank you. Our next speaker will be Mikkel. Mikkel, just introduce yourself shortly and we can start your video.
Okay. Hello, my name is Mikkel. I'm a PhD student from the University of the Basque Country in Spain. So please, Els, can you put the video?
Hello, ladies and gentlemen. My name is Mikel Eturiondo, and this work has been done by members of the Group of Signal and Communications from the University of the Basque Country in collaboration with Oregon Health and Science University and the Medical University of Vienna. We all know the importance of high-quality ventilations during CPR. Several studies have already characterized manual ventilations during CPR in terms of ventilation rate to avoid overventilation by using waveform capnography or transthoracic impedance signal. However, little has been published regarding other features of ventilation like volume or flow, which are generally not available in the field. Thus, a large gap exists between current knowledge of ventilation quality and its optimal implementation. In this context, the purpose of this retrospective study was to characterize ventilation rate, flow, volume, and inspiration and expiration duration of manual ventilations performed during CPR. The dataset analyzed in the study was a subset extracted from a prospective single-center cross-sectional study of 24 ICU patients undergoing CPR, conducted at the Department of Emergency Medicine of the Medical University of Vienna from 2012 to 2014. During CPR, ventilations were manually performed using a back valve mask before connection to a ventilator. You can find a more detailed description of the database in the reference below. Cases included waveform capnography, ventilation volume and flow signals that were recorded using an echo monitor from Philips. During this extraction, only 6 cases were found with concurrent CPR and waveform capnography, yielding a total of 2 hours and 17 minutes of analysis. Now, I will briefly describe the data annotation process followed in the study. First, we identified manual ventilation intervals with simultaneous chest compressions. Second, concurrent waveform capnography, volume and flow signals were analyzed. To do so, volume and flow signals were low-pass filtered to remove chest compression activity. To finish, the following annotations were made on a single ventilation basis. The start and end of each ventilation, the vertical green lines, were annotated by inspecting the zero-crossing instances of the filtered flow signal, depicted in red in the bottom panel. Then, the maximum volume value and time were annotated, using the volume signal. Using these annotations, inspiration and expiration durations were computed. Finally, ventilation rate was also annotated. 4 cases met the inclusion criteria, all of whom were male. The other 2 cases presented unreliable manual ventilations or just mechanical ventilations. 3 of the patients achieved ROSC during resuscitation and 1 of them received mechanical chest compressions using the Lucas device. Overall, a total of 1,412 ventilations were annotated. The following slide summarizes the results obtained in the study. Box plots show the distribution of the studied features for each of the 4 cases. From left to right, ventilation rate, volume, duration of the ventilation, and inspiration-expiration ratio. Ventilation rate presented median values between 10 and 22 ventilations per minute, depicted with red lines in the box plots. Ventilation volume median values range from around 400 to 800 milliliters. And as it can be seen in the box plots, ventilation volume increased as ventilation rate decreased and vice versa. Ventilation durations varied among cases, with median values between 2.4 and 3.2 seconds. Finally, durations of inspirations were shorter than those of expirations, with a median percentage value between 33 and 47%. To sum up, the analyzed ventilation features showed a significant variability among cases. Currently, CPR feedback systems are primarily focused on chest compression components such as chest compression rate and depth. Hence, the design of tools or guidelines to standardize manual ventilation during CPR could be of great benefit. Finally, I would like to thank all the researchers involved in the collection of the database used in this study. That's all. Thank you for your attention.
Thank you very much. As I see, there's no question from the audience yet, so I will pose a question. Maybe if anyone has a question, you can write it in the box so I can read it afterwards. So, Mikel, you analyzed bag valve ventilation. What do you think would be the role of a respirator mechanical ventilation during CPR? Or do you think each patient during CPR should be ventilated by hand with bag valve ventilation? What's your opinion on that?
Well, I think that the problem nowadays is that manual ventilations are not controlled. I mean, as opposed with chest compression, we have chest compression rate, depth, and everything established. But with ventilation, we only just give ventilations no matter what, okay? So, for example, with mechanical ventilators, we have a precise ventilation rate, a precise volume, a precise flow, everything. So with this study, what we wanted to do is to characterize other things from ventilation as we do with chest compression rate or chest compressions.
All right. So you would suggest to have concise guidelines or recommendations on how to do the ventilation during CPR exactly, and you think it's not that clear right now. Is that correct?
Yeah, that's the thing. Nowadays we are using entitled CO2 values to take some kind of decisions during resuscitation. So we have a few studies done that they say that if ventilation rate is not constant, entitled CO2 values are not reliable. So with this study, what we are wanting to say is that we need some kind of standardized ventilation rate or the way of providing ventilations to a patient, well, manually at least.
All right, thank you very much. And
You're
I'll
welcome.
hand to Carsten for our next speaker.
No, we got some time left, and we got some questions. So I think we can focus on them. So let's start with, let's get back with Teresa. She has been asking, Mikel, what do you think is the bigger problem, large tidal volumes or high frequency?
Well, there are some studies that say that higher frequencies are not harmful. It's the amount of volume what is harmful for the patient. I think that it's something related because if you see in the results, you can see that higher rates, for example, they have less volume, and lower rates, they have higher volume. So you have to take care and try to not give too fast ventilations, but with a lower volume.
So this is kind of like the intensive care approach, high frequency, low tidal volumes to have a lung protective approach.
Yeah.
Okay, so we got an interesting question from Robin Davis. He's asking about skills and experience level of the person doing the ventilations, and does this matter?
Excuse me, can you repeat the question?
So Robin Davis is asking about skills and experience, kind of competence of the providers doing the ventilations, and he wants to know if this matters.
Okay, so I think that the skills are very important. So providers should be trained to give or provide good ventilations or ventilations of high quality, as they also train to give to provide chest compressions. So we have to try to do something similar with ventilations in this case.
Okay, so yeah, thanks. A lot of questions coming in, but I think we need to postpone because I'm conscious of timing. Thank you very much for that excellent presentation, Mikael.
Yeah, just one thing, if they have any kind of questions, in my video is the email there, so they can ask whatever they need.
This is one of the options, and the other option is that you still can answer that questions in the chat. That's in parallel to the presentation. There you'll find all the questions that are coming in at the moment.
Okay.
Fine, thanks for that. Yeah. So now let's move on to Youssef from Spain, and he's talking about mechanical chest compression devices and an interesting approach in trying to find out how and if they harm.
Hello. Hello, good afternoon. My name is Youssef Aceli. I am from the Emergency Medical System of Catalonia, and I would like to present this lecture about the relation of the injuries and the chest compression force variation that we think can bring interesting information about the biomechanical behavior of the chest during CPR.
Can we get the video else, please? Yeah.
Good afternoon, everyone. I am Youssef Aceli from Catalonia, Spain. Thank you very much for attending this presentation called Force Variations during Mechanical Compressions and Their Relation to Thoracic Injuries Secondary to CPR. I have no conflicts of interest. We face many challenges during our resuscitation, but one of the main challenges is to maintain the cardiac output over time, because it's key to bring to the patient the possibility to benefit from treatments as ECMO. There is a great incidence of CPR injuries, and this raised with the increase of chest compression death recommended in the successive guidelines. Very little is known about the adverse hemodynamic effect of CPR injuries. We have reviewed and analyzed this issue using the Canva diagram, which highlights the need to maintain the mechanical properties of the chest during CPR. The aim of this study is to determine compression force variation made during mechanical compression and its relation with the CPR injuries. The information was obtained from the RECAPTA study, which is a prospective out-of-hospital cardiac arrest registry including multiple sources of information for the study of sudden cardiac death. RECAPTA includes a specific protocol for the study of CPR injuries. The inclusion criteria were non-traumatic cardiac arrests, over 18 years old, receiving mechanical compressions with Lucas II, available data from forensic autopsy performed. Regarding the data analysis, data was collected from the Lucas II memory card of the resuscitations attempted between January and November 2016. Regarding the statistical analysis, the compression force variation was calculated as the difference between the maximum and the minimum force values during the first 30 minutes of CPR. This force variation could be positive or negative. ROC curves for different injuries were built to know the best predicted force variation. The optimum threshold variation compression force was 95 newtons, predicted bilateral rib fractures, with an area under the curve of 0.79. What happens with the distribution of the chest compression force variation? We found a high increased chest compression force variation group as you can see in the top of the figure for variations above 95 newtons. We found a high decreased chest compression force variation in the bottom of the figure for variations below minus 95 newtons. And finally, a low chest compression force variation group between them. Now, let's take a look at the comparison of the study sample according to the force variation. 39 patients were included. 43.5% of the sample presented high increased force variation, followed by 36% with low force variation, and 20.5% with high decreased force variation. Regarding differences, there were none in compression depth and in the compression force between groups, nor regarding sex and age. The incidence of external fractures were higher in the higher force variation groups. Median fractures were 8 and 9 in the high force variation groups, and 2 in the low variation force. The incidence of bilateral fractures were higher in the high force variation groups. To conclude, most patients presented a high variation in compression force during mechanical CPR, which was associated with rib cage injuries. This is due to a loss of the chest wall elastic force. The variation in compression force could be a marker of the deterioration of the mechanical properties of the chest and a new tool to monitor and improve quality of CPR, moving towards a more personalized CPR. Thank you very much for your attention.
Yes, so thank you very much for that excellent presentation, Joseph. One question I had when I had been looking at that video, so you're describing force variations, so you're describing an increase and a decrease in force variations, and both seem to be kind of negatively associated with the number of injuries we find. Looking at the conclusion where you say that this is kind of change of the chest structure, this is it more the increase or the decrease in the force you find that causes that adjustment, that changes?
Okay, this is a very interesting point because we haven't expected these results because Tomlinson in 2007 described mostly of the cases a high decrease chest variation in force. He described only in 10% of the cases a high increase of the chest compression force variation. Okay. It was surprising for us to find that mostly the major part of the patients present a high increase in chest force variation. Okay. The fact is the chest biomechanical behavior involve two mainly force. One force is the chest wall elastic force exerted by the osseous and the cartilaginous system. And the other one force is the damping force exerted by the intravisceral, the intrathoracic visceral, like the heart. Okay. There is a loss of the elastic chest wall force in both cases. In the case of the increased chest force variation and in the case of the decreased force variation. But what we found seen in subgroups that the heart, the weight of the heart and the chest wall thickness of the heart in the group of the high increased chest force variation is greater. That indicates that the heart has that indicates that the heart is the principal responsible of the damping forces. And for understand the decrease in the chest wall variation force, we have to understand that there is a molding of the chest, and this chest molding leads a fold of the chest anterior wall of the chest, increasing the damping forces of the heart. This is the first important concept. And the second important concept that leads a chest increase force variation is the phenomenon of the stone heart that occurs when the CPR is longer and longer. Okay, the summary of this is there is always a chest wall elastic force, and in some cases, depending on the damping force exerted by the heart, there is as well an increase of the chest force variation.
Wow, yeah, this sounds really interesting. Yeah, many thanks for that nice explanation. I got a question from Michael Borbin. He wants to know if you found more sternal fractures in females in your results.
Not in our series, because females are younger than males. It's usually to find more females that the female is associated related factors of chest injuries, but not in our series.
Okay, and then James Russell wants to know if you have any information about the relationship with the variation in peak force, cumulative force, and duration of the mechanical CPR.
Yes, we found an increase of the chest an increase of the injuries with the longer chest mechanical compressions.
Okay, so what I would be interested in, would it eventually be possible that the application of the device plays a role in that just under this force variations? Yeah. So if the application is done in the right position or the application is done in a somewhat different position?
I think the application could be to build predictive models to predict the chest compression force variation. And this is important because an increase of the chest compression force variation, a positive or a negative increase, indicates a loss of the elasticity.
Okay, so then I got a question from Sebastian. Yeah, Sebastian wants to know if there's an association of higher force variations and the outcomes, so the Ross grade, for example.
This is the very first results about the chest force variation, and we have relate this with non-survivors, and we study this in autopsies only. I hope that someone could check this in survivors and in non-survivors to relate this with survival, which will be great.
Okay, so, okay. Thank you very much. This was a very interesting presentation, and I'm going to hand over to Sebastian again for the next presenter.
All right, thank you. Our next presenter will be Cody, telling us about new information on drowning and CPR. Cody.
Hi, Sebastian. Thanks for introducing me. I'm an emergency medicine resident from the University of Calgary in Canada, and I'm here representing 3 organizations today: the International Drowning Researchers Alliance, the International Life-Saving Federation, and the International Maritime Rescue Federation. So Else, if you'd like to play the video, we can chat about it after. Hi everyone, my name is Cody Dunn, and I'm excited to talk to you today about a new position statement describing resuscitation of the drowned person in the era of COVID-19. The authors have no disclosures. We know that drowning will result in cardiac arrest if left untreated, and that the 2 most important predictors of outcome are how quickly the person is removed from the water and how quickly after resuscitation is started. Several studies have now demonstrated improved outcomes with CPR, which include ventilations, over compression-only CPR. However, the dogma that a drowned person requires ventilations was challenged as COVID-19 became prevalent, and organizations like ILCOR began to recommend for lay rescuers compression-only CPR, especially for adults, as a means of reducing the risk of infection to rescuers. Lifeguards, however, have been trained to do CPR at ventilations, and they knew the benefit for the drowned person. They also felt like they didn't clearly fit into the lay rescuer or the healthcare worker guidelines, and thus there was confusion. 3 organizations, which represent the major aquatic rescue networks from around the world, joined together to form guidance for the lifeguards in these uncertain times. They've reached out to their core membership and asked what local protocols for resuscitation were being created now with COVID, and also what recommendations they would support for lifeguards moving forward. The response was overwhelming, with 56 different experts from 17 different countries with a wide variety of expertise getting back to the organizations with feedback. The end result was an 11-page position statement that was geared towards aquatic organizations and helping them provide guidance on how their lifeguards should respond in this new time. It included 8 focus areas with topics relevant to the lifeguards and aquatic organizations, such as PPE, infection risk mitigation, and education and training. Notably, it also included a new resuscitation algorithm that was designed to help aquatic organizations decide whether or not their lifeguards should do ventilations in this time. And it broke down to 3 simple questions. Based on local prevalence data, was this a low-risk rescue? Was the injured person a child? Or was there a close contact or household member trained and willing to provide ventilations during the rescue? But there were challenges to overcome. Our lifeguards practice in a wide number of settings, from large teams with pre-hospital or EMS level of equipment to single rescuers with practically no backup and no equipment to provide the care they need. To address these concerns, the working group employed 3 strategies. The first was we made the recommendations focused on aquatic organizations instead of the individual guards. This allowed aquatic organizations to assess the risks from time to time and decide how all of their lifeguards should respond at that present moment, instead of lifeguards having to decide whether or not to do ventilations during a resuscitation by themselves. Secondly, for all of our recommendations, we identified that some organizations would not have the support or the equipment to do certain options, and therefore may want to accept a higher level of risk in order to still respond to the drowned person. In order to provide them with best informed practices, we outlined several categories of an increasing risk that would allow them to be informed in making any decisions on how their teams were going to respond. Finally, we highlighted that we didn't have all the options yet. We didn't have all the evidence. So we needed more data in order to better inform practices moving forward. The next stages have already begun. The working group has reconvened, and we're now evaluating emerging evidence and how it's going to impact lifeguards moving forward. Version 1 is also now online and can be found at the link or by scanning the QR code. And by viewing that, we hope some of you will provide feedback on your thoughts about the options and data presented in the document. As well, it's an interesting read to think about who else might fall through the cracks in your community that don't quite fit into the lay rescuer or the healthcare worker guidelines and may need some additional support and guidance during this pandemic. In summary, lifeguards are in a unique situation during the pandemic and require guidance on how to respond. Described as the first urgent global consensus process used by the drowning community, and an updated statement and algorithm is forthcoming and will be available soon. Until then, we encourage public feedback on draft number 1. Here are the references. Thank you so much for your time.
Thank you, Cody. As there are no public questions yet, a question from me. Were you concerned at all that, introducing an algorithm to not that experienced CPR providers would cause a delay in care that would be even worse than just telling them, okay, do chest compression only? Or have you thought about that?
Yeah, it's a complex question, and it's one that we certainly considered early on. The data shows time and time again that compression-only CPR just is not equivalent to compressions with or CPR with ventilations for the drowned victim. And the earlier they get ventilations and oxygenation, the better their outcomes. To target that, we tried to focus on big picture, and we really aimed at national or regional aquatic organizations who would actually be certifying and doing the training for these, as opposed to small individual agencies that, you're right, might have increased confusion or uncertainty in how to implement these changes. So we tried to aim big to capture everyone at once.
Right. In the end, you said that there would be, or maybe you're open for suggestions for other groups or professions that could fall into this gap, you said. Could you maybe give examples for that?
Yeah, I think when I said that, there was always a number of individuals or professions, or in particular volunteers, who have a certain level of training that probably goes beyond a typical standard first aid course or a basic level first aid course, but don't have all the support, finance, and financial support of, say, an EMS, emergency medical services system. And I think we've just got to be aware that when people have a certain level of training but don't have a certain level of support, backup, or equipment, they exist in our communities. And I think we just need to be hyper aware that sometimes the guidelines don't apply one way or the other. And they really we need to focus on, okay, what can we do to keep these people safe without making them feel like they're going below their training or not doing the right thing for the patient?
Okay, thanks. There's a question from Carson. What about the use of filter systems?
Great, yeah. And do you mean viral filter systems, like attached to the mask? Yeah. So they're actually included in the recommendations. It was probably one of the biggest conversations we had about what oxygen delivery systems are we going to recommend. And in all of the options that require someone giving ventilations, whether that's by a bag mask or by a mouth to mask procedure, we recommend they do use a viral filter that's commercially available. The challenge becomes, some facilities don't want to accept the risk of mouth to mask, and others don't have the financial support to get the bag mask. So we were left with kind of a middle ground of giving them several options from best, safest to least safest, and then associating with it equivalent risks for each level, so they could at least make an informed decision moving forward. But it certainly is a challenge when you're trying to come up with a guideline for so many different populations at once.
Okay, thank you very much. It's an interesting topic, and I'm looking forward to reading the whole statement.
Thank you.
And I'll hand over to Carsten again for next and last speaker.
Okay, so thank you very much. Next speaker is going to be Valentin, and she's talking about out-of-hospital cardiac arrest in pregnant women. Looking forward to your presentation, Valentin.
Hello everybody, I'm Valentine Barthes from the French out-of-hospital cardiac arrest, and I'm an epidemiologist. And I'm sorry for the video, it's a very hard exercise to record myself, so you can go with the video. Good afternoon everybody, thank you for watching this video. I'm Valentine Barthes from the French National Cardiac Arrest Registry, and I will introduce you our study regarding out-of-hospital cardiac arrest in pregnant women in France. The literature on the issue of cardiac arrest during pregnancy is really limited. What do we know on this issue? We know that the estimated annual incidence is 1 in 30,000 inhabitants. We know that a part of international guidelines of care during out-of-hospital cardiac arrest is dedicated to this special issue. So we wanted to observe and describe a cohort of pregnant women victims of out-of-hospital cardiac arrest regarding the context the care and outcomes. This is a descriptive and multi-center study. Data used in this study are extracted from the French National Cardiac Arrest Registry, the REAC registry. During the study period between 2011 and 2019, we recorded in the registry more than 100,000 out-of-hospital cardiac arrests. And among this cardiac arrest, we observed pregnant women for 52 victims of cardiac arrest. As a result, we can see that the median age of this pregnant woman was 32 years old. A presence of witness was observed in 71% of cases. The cardiac arrest occurred at home in more than 80% of cases. Cardiopulmonary resuscitation was initiated by the witness for more than a half percent of cases. Mobile medical team initiated a CPR in 98% of cases. This is much more than we usually observed. The first recorded cardiac rhythm was in 76% of cases unasystole, and the use of adrenaline was recorded in 94% of cases. If we look now about etiology of the cardiac arrest, in about 85% of cases, a medical etiology was recorded. Traumatic overdose and drowning was recorded in less than 10% of cases. Now, if we observe the survival rate, return of spontaneous circulation was observed in more than 40% of cases. All these women who experienced a WASC arrived alive at the hospital admission. However, 30 days after the cardiac arrest, only 30% of women were alive. Among these alive women 30 days after the cardiac arrest, about 50% had a good neurological outcome. In conclusion, we can see that in France, practices seemed in line with guidelines, especially if we look on epinephrine use, adrenaline use during out-of-hospital cardiac arrest care. Survival rates are extremely low if we look the median age 32 years old. Only 13% of survival is extremely low. The loss of women between the admission at the hospital and 30-day survival should be investigated. Thank you for your attention.
Yeah, thank you very much, Valentin. This is very impressive and very interesting work. Perhaps I did not get it in the beginning. Where is the location of that cardiac arrest? So, in which part of France have these cardiac arrests happened?
Our registry is national, so it's spread in the entire France.
Sure, cases from all over France.
Yes.
Okay. Did you do anything, or did you find any different treatment measures from standard management of cardiac arrests?
No, we did not observe a difference.
Okay, so no different positioning, no need for early intubation in that patient. Is intubation a standard measure in your pregnant patients in the pre-hospital setting?
No, we did not observe differences regarding intubation or that kind of care. However, this was a preliminary study. Hence, we want to make a more detailed study with a special care for pregnant women. So in this study, we did not record any special care for this pregnant woman. We want to perform a future study.
Of course, my idea behind that is that you perhaps might have a higher rate of aspiration and pneumonias in that patients or something like that, because just due to the specific pregnancy-related changes.
Yes, we don't see that in that study, but I think we should observe that in the future study.
Do you have any information about the children?
The chicken.
The children.
Children. No, sorry.
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 German is talking English to a French person.
Yes, and we know that French persons are not the best English speaker.
It's the same for German, yeah.
No, we are looking for children's survival, and for this 52 women, we know that 30 children are dead, but we have not the answer for the 22 other children.
Okay. So James Russell wants to know how the incidence is compared to the incidence in non-pregnant women in France.
We can't compute incidence in this study because the pregnancy status of women were not compulsory in the registry. So we don't think that we know the pregnant status of all women in the REAC registry. So we can't compute incidence, and we can't compare incidence of pregnant women and other women. It's not a data that we have. But in the study on pregnant women, we hope that we will have an incidence number, and that we will be able to compare with other cases of out of hospital cardiac arrest.
Yeah, that would be interesting numbers. Thanks.
Yes.
Any additional questions? So there's nothing coming in at the moment. So Jack is asking, he wants to have information about the gestation age, so the number of weeks of pregnancy in the women. Do you have data on that?
We have data on clinical observation. So we have the 50% of women who were in the first trimester. For some women, for 20 women, we don't have the information, and for 12 women, they were in the last trimester of their pregnancy.
Has this been outcome relevant in any case?
We are not able to compare. There is no outcome. There is no incidence on the outcome.
Perhaps would be interesting to add that to the information you have from that data.
Yes, you're right.
Okay. Sebastian, do you have any additional question?
I didn't quite get it. I don't know if you said it, but you said you didn't do any special positioning, no special other treatment than in normal adults, because there's a suggestion to shift the belly if it's really advanced pregnancy and so on. So data on that would also be interesting, of course, and outcome data. Yeah. Okay.
Yes, you're right.
Okay, so thank you very much, Valentin, and thank you very much to all of the speakers for that excellent session. So I think we covered a broader range of topics. And we had very interesting discussions. Discussions have been going on in the chat, as I have noticed. So thanks for all that activity, and I hope you will enjoy the rest of the conference, and we will meet in one of the other sessions. Thanks to Els for the nice technical support. It worked pretty well. Have a nice evening. Enjoy the rest of the conference, and goodbye.
Bye-bye. Thank you all.